All right, part 3 of chapter 16. Part 3, well actually part 1 and part 2, we covered really the kind of physiology, the anatomy, and some of the minor assessment pieces that go along with airway management and oxygenation, ventilation, so on and so forth. So probably what most people are excited to get to is part 3 here, where we actually cover management of these things. So how are we going to use the various skills we have to do many of these things? So this is probably what a lot of you guys are anxiously awaiting. Now, I will remind you that many of these things are actually review items from being an EMT. If you were an EMTB and had completed supraglottic airway training, i.e. the LMA, I'm sorry, not the LMA, the King Airway, or even the combi tube, a lot of this is really going to be repeat. Now, there is a separate little video lecture that talks a little bit more about King Airway that you'll find in this week's course page as well. But on with the airway management. And as a reminder, if you have not read the chapter, this lecture is no substitute for reading the chapter and studying with notes and whatnot. It is intended to be supplementary. So, left lateral recumbent or the recovery position. This gets used as a form of airway management. You may look at this and think, how in the heck can this be airway management? They're not doing anything. Well, it is. If the patient's unresponsive and they're unable to maintain their own airway, placing them in the recovery position like this, or the left lateral recumbent, whatever you want to call it, is a way to allow drainage from their mouth and nose, for that matter. So it is a form of airway management. We can position their head somewhat in order to try to maximize their ability to exchange gas, or exchange air, I should say, move air. And so it can be an easy first step, particularly if it's somebody that we're expecting we're going to have wake up very soon. So positioning and manual maneuvers. If we have a patient that's sitting upright and able to hold their head upright, generally we're in good shape. If they're not able to do that, then placing in the lateral recumbent position can help prevent aspiration. Sitting or sitting forward can help them move that fluid and solids out of their airway, but if they're sitting straight upright but completely unresponsive, they're really not protecting their airway. And we may use one of the two manual maneuvers that we commonly discuss: head tilt chin lift versus modified jaw thrust. Head tilt chin lift is the preferred method and used in cases of medical patients, and the modified jaw thrust is used for patients with suspected spinal trauma. The head tilt chin lift, the advantage of that is it rotates everything, kind of lines things up, and but it does move the spine significantly. With the modified jaw thrust, we're simply pulling the jaw forward. With the jaw jutting forward, then it basically will cause the tongue to come forward as well. So there's representations of this on 390 and 391 in your textbook. If you have not remembered these from way back when, there's a good reminder for you. If we have the patient that we're doing a head tilt chin lift on, it's really simply placing one hand on their forehead, another couple fingers underneath their jaw, and rotating their head backwards, so their nose is basically stuck up in the air if they were standing upright. The modified jaw thrust, on the other hand, we're ensuring that the patient is in a supine position, or maintaining manual C-spine mobilization, and then we're just simply taking our fingers, placing them behind the patient's jaw, the crook of the jaw underneath the earlobes, and pushing the jaw forward. The mandible gets moved forward. So that's really the extent of those. They're not difficult by any means. So we will move forward. to removing foreign bodies and fluids from the airway. There's often many things that get found in patients' airways. Trauma patients and responsive patients may have any and or all of these. Blood, vomitous secretions, and broken teeth. They may have food, they may have foreign bodies, toys, pen caps, whatever. There's lots of potential things that we're going to find in patients' airways. Before we would initiate any positive pressure ventilation, we need to check for those things, and we need to get them out of there. So we have some methods that, of course, we can use. We've touched on them briefly, but to move some of these things out of there, of course, we can tip them up, use a gloved finger and a piece of gauze to help kind of sweep it out. Remember, we do not do blind finger sweeps on children, so unless we have something in there we're physically trying to remove on infants and small children, do not blind finger sweep. We can also use devices such as forceps or suction. So if we have liquid, suction works. If we have very small chunks, suction works. If you have large chunks of broken teeth, chances are good you're not going to be able to get that with your suction. Food, gum, chewing tobacco, edema are additional things we may run into from time to time. Suction may or may not work on these as well. With edema being very frothy and foamy, more like you overfilled the sink with soapy water, you may not be able to suction that very well. You can get into the back of the throat and hopefully eliminate some of that. Gum's good and sticky, might stick to stuff. However, chances are probably fairly decent that you can get that with a Yankauer or a rigid suction catheter. Food depends on how small it's cut up and how well it's chewed up. Chewing tobacco is very fine shred, so suction may or may not get it. It's just a tough call to say whether you're going to get that. So you may need to look at what it is you're trying to get out of there and make some judgment calls. All right, so if we have noisy breathing, we generally have a partial airway obstruction. If we have a harsh crowing sound of stridor, usually indicates it's an upper airway obstruction. Whereas if we have localized wheezing in one lung, we may have a partial obstruction of the bronchus. And then bubbling or gurgling sounds is usually representative of fluids in the airway. So to remove these, position the patient on their side if you can. Sometimes it's difficult to do one person, but if you have the abilities, if they're on a backboard and they're immobilized well, voids are padded, you can move the backboard up on his side. Again, gloved hand, gloved fingers, potentially with a piece of gauze in there. Gauze is nice and absorbent, so it can get some of those fluids. You can then sweep the matter out. This is kind of a disheartening procedure to do, simply for the fact that you're sticking your finger in somebody's mouth, and it is very, very possible, even as young as 6, 7, 8 years old, for children to have enough power in their jaw to actually bite through your fingers. I don't say this in order to frighten you, just more to make you aware that, hey, there is the potential out there. Be very aware of what's going on. So you position them on their side, gloved hand, potentially with a piece of gauze there, and sweeping, and then suctioning. Suctioning can help after the large debris is removed. Copious amounts of fluid can be removed manually. So that suctioning gets the last little bits, it gets the fine stuff. I have had patients who, when they vomit, has not been much liquid at all. In fact, I remember going on a cardiac arrest one time in which the patient had just finished eating, and he had a nice large steak, and he actually vomited into a pile. It was not a puddle of vomit, it was a pile of vomit. And it was just because everything was still so semi-solid. All right, foreign body airway obstruction. If we're dealing with the foreign body airway obstruction, then we have to obviously remove that very quickly. We need to get that out of there via the appropriate method. pictures on pages 392 and 393 give us some reminders of how we're appropriately supposed to remove foreign body airways, or foreign body obstructions, I should say, from the airway. On page 392, you have the figures representing adults that we would be doing the Heimlich maneuver on. As the second one down there as an obese gentleman, or potentially could be used in a pregnant woman, where you would go low on the sternum but above the xiphoid process. On 393, the first picture there, 1624, represents pediatric Heimlich maneuver or abdominal thrust, and then on the right side of the page there, picture 1625 shows us proper placement and technique for infants. So when is it that we go here, and when do we go this far? When we have complete obstructions of the airway. So if we have a complete obstruction, we go there. If we have a partial obstruction where some air is moving, they're coughing a lot, they maybe can squeak and spit and sputter a little bit, we generally are going to encourage them to try to cough it out on their own, to not jump directly to thrusts and what have you to get this device or get this object moved out of their airway. Most people can handle it. Most people can get it on their own. So we encourage them. We're standing by, of course, should something happen that we need to intervene further. So our signs of severe airway obstruction, if you're looking for that, we would then sorry about that. The signs of severe airway obstruction, those things would include silent ineffective cough, cyanosis, inability to breathe or speak. So if the patient can move air, we encourage them. If the patient can't move air, we step in. So removing the foreign bodies and fluids. Do not interfere with coughing and breathing efforts of patients with mild FABEO, foreign body airway obstruction. The patient is usually maintaining their own, doing fine, again, standing by just in case something should happen. Conscious patients with severe foreign body airway obstruction. In the adult, we use the repeated abdominal thrust to clear the obstruction, and we usually do this until the point in which the obstruction is relieved or the patient becomes unresponsive. If the patient becomes unresponsive, we lower them to the ground and we can begin CPR. Something to keep in mind, if the patient has the severe foreign body airway obstruction, we were unable to relieve it by doing our abdominal thrusts, we may need to make the choice to get the biggest breath of air we can, seal our mouth around theirs, or with the pocket mask that we're going to use, and pinch the nose, unless we're using the pocket mask, and just blow as hard as we can. This is probably going to move that obstruction into one of the lungs. While that's not great, it's better than dead. They can go in there later with the scope and take that out. But if we do nothing and we just continue to push on their chest and don't get their airway obstruction relieved, then they are going to die. Now, the good thing about CPR these days, particularly when they're telling us that compression-only CPR does benefit some patients, doing chest compressions could help relieve some of this obstruction by forcing some of the air from the lungs upward and trying to push it out the trachea. So, in the pediatric patient that's coughing, trying to clear their own airway, again, we're going to encourage them to continue to try to cough and clear their own airway. In the unconscious child with the severe obstruction, we'll do the subdiaphragmatic abdominal thrust in the same manner you would the adult. Isn't that kind of a hot $20 word for saying the Heimlich maneuver, subdiaphragmatic abdominal thrust. Sounds very impressive. If the child becomes unresponsive, again, lowering them down to the floor, and then starting our cycle of compressions, and then using, obviously, our head tilt chin lift or modified jaw thrust. If we're talking infants, then we include chest thrusts and back blows. Much the same way, and it's usually a magic number of 5 or so, where we'll give 5 back blows, 5 chest thrusts, in an attempt to remove the object. So they're showing trying to relieve the airway by or airway obstruction by doing back blows. Something I like to recommend when you're going to do this technique: place your fingers in a V shape, one on either side of the infant's mouth. And with that, you are supporting their head a bit. And if something falls out, there's a good chance it's going to come up and brush against one of your fingers, and you may feel it. So don't have your fingers together, covering their mouth and nose completely, but just off to the corners of each side of the mouth, just as an extra added form of protection, essentially. So, again, the conscious infant combination of back blows and chest thrusts, simply for the fact that the child, if they're unable to cough, then we're not really going to be able to encourage them. Do not use abdominal thrust on the infant. They don't have the musculature for it to work. And then with the unconscious infant, the same procedure as the unconscious child with a severe foreign body air obstruction. We're going to start compressions. So additionally, suction. Suction is using a vacuum cleaner. And this vacuum cleaner is going to remove fluids and small particulates from the airway, really anywhere that we can kind of get to. We typically will use either rigid or flexible suction catheters. The preferred would be the rigid suction catheter, also known as the Yankauer. And the Yankauer catheter tends to be the most effective device when we're suctioning oral cavities. If we're talking nasal cavities, or we would need to suction a tracheostomy or through a tube such as the King LTDS. King LTDS has a suction port. We can use flexible suction catheters to get into those areas. Properly functioning suction needs to have a flow rate of around 30 liters per minute with no less than 300 millimeters of mercury when the suction tube is clamped. So you should be able to, on a lot of your devices, you will have the electronic devices, I should say, automated devices. They'll have a gauge that measures how much suction is being applied. If it is completely clamped, then you would you want to see no more than 300 millimeters of mercury. So you can adjust some of those vents on there. This is not something you should have to do at the time that you need to suction a patient. Part of regular maintenance on the truck should be double checking the suction. I talked about the rigid or the soft catheters, or what are often called French. Get used for suctioning tracheas, nasal airways, and whatnot. Do not delay suctioning if the patient is in immediate jeopardy of aspirating fluids. Now, we also know that we tend to have certain times in which we're not supposed to exceed when we're suctioning patients. I think you have to really look at it from a reality perspective. Is even though it may say don't suction for longer than 10 or 15 seconds, and in the case of this textbook, they really say don't suction an adult for longer than 10 seconds. Some other books say 15. Even though they say that, if you're almost got them done, or they still have a mouth still full of stuff, you need to continue to suction. You give them a breath with this mouth only half full of crap, you're going to blow that stuff into their lung. If you never get there, if you never get it emptied, of course, then yes, you're going to need to to give them a breath, and we'll just have to deal with it later. But if you're almost there, get it done. So, French suction catheters or flexible catheters are actually measured in the French unit or French system, and 1 French is equal to 1/3 of a millimeter, so 0.33 millimeters. So therefore, a size 16 French suction catheter is 5 1/3 millimeters, and 18 French is a 6 millimeter in diameter. So with that being said, this is not the same as gauge. Gauge, remember, the lower the number, the bigger it is. French, like your nasal cannula, or I'm sorry, nasopharyngeal airways. Nasopharyngeals are a lot of times 20 to 36 French, and those French sizes, the bigger the number, the bigger the tube is. So, suction risks. We can worsen our hypoxia. We can cause hypoxia if we're not paying attention. We can just continue to suction and suction and suction and suction and suction. If that's the case, we're not only suctioning fluids and whatnot, we're suctioning air and oxygen and the good stuff. We can cause trauma to the oropharynx. If we're not careful, we're banging around in there with a yank or a hard plastic piece of equipment, we can lacerate or puncture structures of their airway. Stimulating the gag reflex. If they're not completely unconscious yet, we can hit the back of the tongue there and stimulate the gag reflex and cause them to vomit more. And then we can also induce bradycardia through stimulation of the hypopharynx. Here's the reason why. There is a cranial nerve, or a nerve that comes directly out of the base of the brain, that feeds down to the heart and eventually stops around the stomach somewhere. And that is called the vagus nerve. So any of us that that like to go to Sin City will easily remember that the vagus nerve can slow us down. Actually, we think of vagus about being fast, but the vagus nerve is one that will slow your heart rate. And it runs down along the sides of your esophagus and can be stimulated by repeated rubbing. There is another way to do this. If you take your fingers, and I don't recommend that you do this, but maybe we'll try it in class one of these days, or in Skills Lab. You take your fingers, you find your carotid pulse, and you just start rubbing up and down, kind of at a, with some moderate pressure, and it tends to stimulate that nerve and it will slow you down. I'll give you another example of how you can see this work. Maybe not the best dinner table talk, but we've all had those times in the restroom in which we maybe worked a little harder than we would have liked to get the job done, and you go to stand up and you're a little lightheaded, or you felt like you were going to pass out even while you were still sitting down. Part of this is because you've strained. The strain puts strain on the muscles in the neck puts some stimulation on the vagus nerve slowed down your heart. So it's a fun party trick, although I don't recommend you do it. So, use your gloves and your eye protection and face protection as a minimum PPE. If you have gloves and eye protection on, fantastic. But you're sitting there with your mouth wide open while you're suctioning this person's mouth out and it splashes up in your mouth, it really did you no good. So if you have that whole face shield, that's great. The face shield where it covers your mouth, your nose, and your eyes all at the same time, perfect. And of course your gloves should go without saying. So if you're going to suction the oropharynx, preferably move our patient into the left lateral recumbent position. Not always feasible. That's the preferred. Remember, let's use gravity to our advantage. Make sure that your suction unit is properly assembled. I'm going to divert here for just a half a second because many cases in which I'm out visiting services and whatnot, I'll see suction units with the canister sitting in the back there, but no tubing plugged into it, no Yankauer suction catheter stuck on the end of it, and maybe even not all the caps are in place to ensure the suction works. This is not something that we are going to need that we should have to take 2 or 3 minutes to prepare before we actually use it. our onboard suction unit, as well as our portable suction units, they need to be turnkey ready to go. If I need it, I grab it, I open it up, I flip the switch, and bam, I should have suction. I think a lot of people look at it as, well, if I open these packages, then I lose my sterility. Okay, good point. However, we're not suctioning anything that's sterile with a Yankauer suction catheter. We are suctioning a person's mouth who is filthy, dirty, and gross. So sterility is not a big deal here. Clean is fine. If we do need to suction somebody's trachea or tracheostomy or whatever, we may desire something that's a little cleaner and more sterile technique. We can get out sterile gloves and sterile water and sterile flexible suction catheters, which are what we're going to use to do that. But the Yankauer, have it all hooked up, have it ready to go. It should not take you any effort to put this thing together before you can actually use it. So also on your portable sections, make sure it's charged. If you have battery issues, get new batteries, swap them out. Some portable sections use the same battery that your defibrillator uses. So you just get a new monitor defibrillator battery out of the charger, plug it in, and away you go. It needs to be checked. So make sure it's assembled. Measure the catheter from the corner of the mouth to the earlobe. In theory, yes. In reality, you suction no farther than you can see. So if you are suctioning the back of a patient's throat there, where you can see the end of the catheter, that's where you need to be. We're not probing the depths of a person's trachea with it. We're not doing an endoscopy. We're not trying to do a proctoscopy from the top down. What we're doing is simply suctioning out the airway. So open the mouth and insert the catheter. Some people talk about a cross-finger technique, and that's fine. We have a cross-finger technique represented on 394. You can use that. In most cases, probably not terribly necessary. Most people that we're going to suction probably are either unresponsive or conscious and alert and able to allow us to do this. You insert the catheter without, quote unquote, without suction being applied. The machine is on. If you're using a machine, the machine is on. You insert the catheter where it needs to go, and then you cover the whistle. So when I say the whistle, people commonly know what I'm talking about when I am referring to a French suction catheter. But on most Yankauers, there's also a whistle. And that whistle is just a hole, a port that allows the bypass of suction. Suction is going to take the path of least resistance. So you've got to cover that hole, or that, sometimes it's a square, but cover that hole with a thumb or forefinger in order to actually apply suction down to the complete tip of your catheter. So you can insert it while the suction is on, cover the hole, and then withdraw the catheter. Move the catheter tip around, making sure that you don't suck onto just one part or one area. Most suction catheters also have multiple little suction port windows in the end of them, so they're not going to just simply grab onto one spot. All right, so oral suctioning. We're moving them to the left lateral recumbent. Applying their, make sure that their suction device is ready to go, flipped on, turned on. They have their BSI on. She's measuring as far as it'll go. Okay, good, fine. She opens up the mouth, inserts the catheter. The problem with this, with that whole measuring how far it's going to go, she's lost sight of that. How far is that it's going to go? So unless she's marking it with the very tip of her pointer finger on the backhand, that's it. So apply suction as you withdraw the catheter. What she is not doing here is covering that whistle. What I tend to think she's doing in this picture, with her pointer finger on the mid part of the Yankauer, is covering that whistle. So suctioning the lower airway. This is definitely something you're going to need to have a protocol on, and medical control. Medical director is approved. Patients who have an endotracheal tube or a tracheostomy tube occasionally require suction to clear their trachea of any secretions. Sometimes, if they have an endotracheal tube, the paramedic is then going to have to take care of that. You, as an AEMT, may be called on to suction a patient's tracheostomy. They're showing actually the changing of a tracheostomy cannula on 394. They don't show the suctioning of a tracheostomy. They are representing the tracheal suctioning of the intubated patient on page 396 in your textbook. So when we're going to suction the lower airway, we're really just trying to get secretions from the immediate vicinity of the tip of the tube. So we're going to try to clear those secretions. When we're talking tracheostomy, we're only talking a couple of inches, and usually they do have a significant amount of secretion. Patients with endotracheal tubes, and occasionally the patient with tracheostomy, do need to be occasionally suctioned deeper. So suctioning this tracheal tube, or you could extend this, I guess, for the tracheostomy. If possible, pre-oxygenate your patient. And kind of give them the added bonus of oxygen, so just in case they're going to be a few seconds without being able to get a breath, we kind of stack the deck for them. Assemble your devices. She's putting together the flexible suction catheter there. You can see the whistle right there by her right hand for that flexible suction catheter. She's measuring down from around basically the ear down to the sternal notch, which is, if you feel your breastbone all the way up to the top where it gets soft, that's right about where she's going. And that's about as far as you should suction, because that's right where the carina is at. They're going to use sterile gloves to handle the suction catheter. So she's taken off of her standard exam gloves. She's applying the sterile gloves. She's going to then insert the suction catheter down the endotracheal tube to the measurement that she had previously done. Most of these also have little marks on them that you can keep in mind how far you need to go. She covers the side port or the whistle there and slowly withdraws the catheter using a twisting motion. In the meantime, continue to monitor your patient. It's a good thing for your partner to be doing to make sure that they don't Brady down. And they're kind of twisting. After your 10 seconds of suctioning, give the patient another ventilation, or it'd be nice to give them 30 seconds or so. If you're going to repeat suctioning, suction a little sterile water through that catheter to clear it up, because there may be thicker mucus in there. And then finally, you're going to dispose of that. So moving to airway adjuncts. Obviously, we have oral airways represented here, and they may or may not be color-coded like these are. There is more than just 6 sizes of oral airways. Then we have preemie size, and we have holy cow size that look like you could put it into a cow, but they vary from patient to patient. Of course, we know how to insert those, but we can watch the video from your non-narrated PowerPoints. So the oropharyngeal airway, or oral airway, or OPA, is a curved device used to displace the soft tissue of the tongue and provide a channel for air to flow through the oropharynx. So with all that being said, it's a tongue holder upper is what it is. It holds the tongue up off the back of the throat. And of course, it needs to be appropriately sized in order to work appropriately. So measuring the correct size of the oral airway includes measuring it from the corner of the mouth to the tragus of the ear, or the earlobe. When it stretches from the corner of the mouth to the earlobe, that's appropriately sized, or pretty stinking close. For most adults, we're going to put it in upside down with the tip pointing towards the roof of the mouth. When we almost touch the roof of the mouth, we'll then rotate it 180 degrees, and it is in correctly when it rests against either the lips or the teeth. When we're talking nasopharyngeal airway, this we can use in patients who are partially conscious. They're maybe not fully unresponsive yet. So we can use this when oral pharynx is not open for us to use, such as maybe a seizure patient with clenched teeth. Sizing is essential. We always need some sort of lube. Water is fine. Water does work. Avoid inserting this into patients with severe head or mid-face trauma, such as a basilar skull fracture. There are documented cases in which nasal pharyngeal airways have broken through the roof of the nose, the floor of the cranium, and have been fed into the brain. If you put this nasal airway in partway up, and you start to get little bits of clear fluid dripping out of the end of your nasopharyngeal airway, that is not a good thing. You've probably broken through into the brain. So we're measuring again, and it's usually from the tip of the nose to the earlobe, or the tragus of the ear, so they're down a little bit. It's not usually the corner of the nose, the tip. The other thing that you have to measure is to make sure, will this tube fit in that nostril? You need to look closely at it and say, okay, does this or does this not look like it'll fit? A little bit of lube is great. Surgical lube like they're using here, which is essentially KY, water works. We're going to insert the airway with the bevel towards the septum, or the base of or base of the tonsil. So the bevel of the septum towards the septum. So that's the part that's cut off. Again, remember when we talked IVs last week, the bevel was up. Well, this is the bevel towards the septum. The reason for that is it's less intrusive on the nasal septum. There's a structure in there called Kieselbach's plexus, and Kieselbach's plexus is a network of capillaries that is very easy to damage and causes nosebleeds. So we're going to advance the airway until the flange is seated against the patient's nostril. Some people think, well, once you get the flange, if you put the bevel in there on the right side, you basically have to turn your airway 180 degrees, so the curve goes the wrong way. Well, it's still going to follow the curve of the patient's airway. If you want to, you certainly can rotate it after you get the tip in there. One thing I would like to remind you, the airway, I mean, if you go about a ½ inch up inside your nostril, your airway is already going backwards. It's not going up anymore. It's going back towards your neck, and then it's already going to turn around and go south. It is not, you don't go up there to halfway between your eyeballs to turn the corner. It's just barely right up in there. So it's not pushing this up. It's actually get the tip in there, and then you can almost make it 90 degree perpendicular to their face there and advance it in. The airway is appropriately seated when it's against the patient's nostril. You would typically see that in the back of the patient's throat as well. So it hangs down just back behind the uvula in most cases. All right, an esophageal tracheal combi tube. So the combi tube is a dual airway device. Supraglottic airway device would be that of like the King airway. These are non-visualized. Intubation, endotracheal intubation is a visualized airway, and the combi tube is not, nor is the King. And so we don't need to worry about this. It's a blind insertion. They're relatively easy to use. They're almost foolproof, and they can be inserted very quickly. Endotracheal intubation is a little bit more drawn out. So the combi tube, when placed in the esophagus, obstructs the esophagus and the pharynx, so the air is forced into the into the trachea, therefore into the lungs. Similarly, the King airway does that as well. And like I said, there's another lecture on the King airway that you'll find in the course page. I'll be posting as well the directions for use for both the combi tube and the King airway. So the combi tube is, or the supraglottic airway, is inserted into hypopharynx. The advantage to the King is it's one balloon to inflate. We don't have to worry about the two balloons. So it's one balloon to inflate, and it inflates both cuffs at the same time. So it creates a seal around that glottic opening. So it's not as far up in the mouth as the combi tubes is. It's just right above the glottic opening, and then right below it in the esophagus. There are some other airways that get brought up. The LMA. LMA is not recommended for field use. The King LTD, which is the one we've been just talking about, and then the Cobra and the Salt airways are a couple of others that have some benefit as airway maintenance devices. So indications of effective and ineffective positive pressure ventilation. After we have an airway, we have to potentially ventilate our patient. So if we have good mask seal over the face, and the mask covers the mouth and nose, if we have issues, we're going to have leakage around it. Tidal volume is appropriate to the patient. Each ventilation is delivered over about 1 to 1.5 seconds until the patient's chest begins to rise. Problems would be indicated if there's no chest rise, no chest fall, or we get abdominal distension. Ventilatory rate is based off of their age group, usually 10 to 12 for adults, 12 to 20 for peds, and a little more than 20 for infants. Outside that, of course, would be inadequate ventilation. Air flows to the lung with very slight resistance, and then inadequately would be there is no resistance to airflow, which it just flows in there easy, or it's so over the top that we can't hardly move any air in. And then if the patient starts to stabilize and improve, it's usually a good sign. If they start to deteriorate, of course, that's not. A couple things to consider. Nosocomial infections. Particularly when we're talking about airways, nosocomial infections usually comes up. These are infections that are transmitted to a patient in a healthcare setting. They're watched very, very closely in hospitals, and to be honest with you, a lot of hospitals believe that there are patients that get nosocomial infections as a result of what EMS did in the field. And so the nosocomial infections are something we have to keep in mind. Try to keep it clean. A lot of patients will die or spend additional time in the hospital due to these infections, and a lot of them are starting to become antibiotic resistant and very difficult to treat. There are bacteria out there now that we cannot kill with our strongest antibiotics. So, as we continue to talk a little bit more about ventilation, we come to talk about CPAP. CPAP is continuous positive airway pressure, and continuous positive airway pressure is a splint for the airway. Now this kind of looks like a regular oxygen mask, but if you look closely you'll see that there's some significant differences there. The CPAP device is used in patients who are starting to falter in their ability to maintain their airway. They maybe have fluid, maybe are starting to have problems with airway collapse. And in those cases, CPAP can help hold off having to go down that road of intubating them and ventilating them fully. So it's a non-invasive positive pressure ventilation. In severe respiratory distress or failure or arrest, we're going to supplement the patient's spontaneous respiratory effort and provide artificial ventilation using positive pressure ventilation. So if CPAP is not an option because they're not alert, they're hypotensive, they're not able to maintain their own airway, we then take the next step and we're going to start to ventilate. So positive pressure ventilation, normal breathing is air movement on inspiration, which is generated by negative intrathoracic pressure. Like I said, you have a vacuum in the chest vacuum sucks air in. When we do artificial ventilation, it moves air into the lungs under force. So it's positive pressure ventilation. This is not what the body's used to, so sometimes it actually bucks it and has a difficult time with it. Examples of positive pressure ventilation are CPAP, bag valve mask, mouth to mask, mouth to mouth, manually triggered ventilatory devices such as the demand valve or automatic transport ventilators. And all of these things are going to force the air in. If we do nothing, though, apnea respiratory failure and potentially apnea have the result of death. So when we're going to ventilate, we need to make sure we have the right type of device to ventilate. The simplest and probably more recommended device in the field setting is the bag mask device, or the bag valve mask. And the bag valve mask has obviously a number of parts to it. We have exhalation ports, non-breathing valves, face masks, the actual reinflating bag itself, or re-expanding bag, oxygen inlets and reservoirs, so on and so forth. And it shows an example of different sizes. So the best way to provide this is to get a good mask seal is a two-person technique. One person holds the mask with what's called the EC clamp technique. You make C's with your thumb and your forefinger, and then the E's are with your middle finger through your pinky finger. You put the E's underneath their chin, pull their head back, and you put the C's around the mask to hold it, to apply equal pressure around the face. The second rescuer then squeezes the bag. So self-inflating bags are attached to a mask, creates that seal. The seal often becomes kind of an issue, and so therefore some of those more advanced airways, such as the combi tube or the King, may be advantageous simply for the fact that we don't have to worry about the seal. Adult, pediatric, infant, neonate size bags, if you don't have the right size bag, but you have the right size mask, you can adjust. You're just watching for chest rise. Once the chest starts to rise, stop squeezing the bag. It requires the patient to have an open airway. If there's no open airway, we don't need to worry about ventilating. The mask covers the face from the bridge of the nose to the depression between the lower lip and the chin, and we're going to ventilate at an appropriate depth and appropriate rate. And what is appropriate? What it takes to get their chest to begin to rise. It's not squeeze that bag completely flat. It's what it takes to get the chest to rise. So normal tidal volume for most adults is 5 to 7 milliliters per kilogram of body weight. So if we're talking a 100 kilogram person, 220 pounds, we're talking 5 to 700. I'm sorry, 5 to 700 cc's of air. The typical adult bag valve mask is capable of delivering up to 1,600 milliliters of air. So we don't need the whole thing. We just need half of it in most cases. The rate, again, is about 10 to 12 per minute. In most cases, there are a few other situations in which we may do something different. In ventilatory, the speed of our ventilations should be over about 1 to 1.5 seconds. Basically, we want to watch the chest start to rise, and then we quit. Additional pressure, going too fast, those sorts of things force air into the stomach, causes gastric distension, and then potentially vomiting. So again, we see this chart. Basically, it kind of mimics what we just saw earlier. Talks about good versus inadequate ventilation. I'll let you read that on page 405 of your text. This is showing a flow-restricted oxygen-powered ventilatory device, or what they call the demand valve is what it's normally called. This is one in which you can ventilate your patient by pushing the button or pushing the trigger, and it will inflate the patient's lungs with air. The problem with this is it requires an oxygen bottle. With a bag valve device, you can continue to ventilate even though you may have run out of oxygen. The other problem with this is a lot of times causes barotrauma. So people don't pay good attention when they use this device, and they usually end up causing gastric distension and vomiting. So these manually powered devices, they deliver positive pressure without you having to squeeze the bag, so that's a bonus. The operator can adjust, and it can actually, or the operator is really the one that decides how quickly and how much, whereas some of the non-manually triggered ones kind of do it on their own. It's kind of an automatic transport ventilator. You have to pay much closer attention to make sure that it's functioning appropriately. So then we come to automatic transport ventilator. And our automatic transport ventilator, there are all kinds of different types of these. Some of them look basically like a demand valve. Some of them mimic more what you see on page 407 in your text, which is a more advanced. It has settings for adult versus child, the rate that you want to deliver, and the volume that you want to deliver. So you are capable of transporting something that's very low-tech like this. It can be delivered basically hands-free, so that's an advantage. It frees up your hands. CPAP. Again, CPAP provides that positive pressure, and what it actually is providing is something called PEEP, which is positive end expiratory pressure. We can administer PEEP on our bag valve masks by putting a valve on the exhalation port. I mentioned that it pneumatically splints, and CPAP is usually set by slowly increasing your amount of oxygen delivered until it gets to a point in which it maxes out. You usually will start with lower pressures and slowly titrate or work your way up. If the patient is not breathing at all, CPAP will not work. So you have to keep in mind, if you're thinking, oh, CPAP may work, it's not a ventilator. It splints and it assists. It is assistive ventilation. It is not sole ventilation. And then it's used to improve their ventilations that they're already attempting to take. And you have to be responsive. They have to be able to follow command. There obviously has to be within one of the medical emergencies it's prescribed for. And they cannot be hypotensive. If they're hypotensive, then it can cause increases in hypotension. It can cause their blood pressure to drop. These are kind of oxygen-hungry devices, so keep that in mind. So mask seal is essential to an effective treatment. You need to choose the appropriate size mask. You need to obtain a mask seal with that EC technique, preferably one person doing only mask seal and another person squeezing the bag. All patients with complaints of dyspnea who are in respiratory distress, failure, or arrest should receive supplemental oxygen. It is beneficial to patients with SpO2s less than 95, but if you're in doubt, give them oxygen. Okay? There's really only three contraindications to giving the patient oxygen. Number one, if the patient is a newborn baby with absolutely no issues, the baby's doing fine, giving them oxygen actually can cause some blindness. Number two, you are a victim of paraquat poisoning. Paraquat is a kind of obscure pesticide that gets used and actually will cause you to burst into flame if you give them oxygen. Or number three, you are actively on fire. If you or your patient is on fire, do not be using oxygen. So here's an O2 cylinder. This absolutely drives me nuts because this O2 cylinder is standing up with nothing to hold it up. No cylinder should be sitting upright like that without some sort of a device to support it. If that thing falls over and has enough force to break the neck on that, it will shoot through a cinder block wall. So select your cylinder, make sure that it is in fact oxygen. This has the look of most oxygen tanks. It's a spun aluminum silver tank with a green cap, and it says oxygen on it. So place the cylinder in an upright position, stand off to one side, remove the wrapper or the seal. Most of them come with a washer or a gasket of some sort. Hold on to that. You're going to need it. Crack the main valves just for a split second there to clean out any dust, air, dirt, oil, whatever that's gotten into the hole. So select the correct pressure regulator and the flow meter, and in our cases we use the same thing in our portables, so it's a flow meter / regulator all in one. The pin yoke system works on the portable tank, so you can see that there is I think you guys can see my cursor here. This is the orifice that the bigger one of the three on the oxygen bottle is where the oxygen comes out. The two smaller ones below there that sit side by side are the pin system that the pins that you're looking at on the bottom side of that regulator fit into. Those pin positions are pin positions 2 and 5. There are up to 6 positions there that the pins can sit in, depending on the type of gas it is will change it. So nitrous oxide has a different number system, and helium has a different system, and so on and so forth. We'll then slide the regulator down over the neck of the bottle. Obviously, the pins are going to have to fit into those 2 holes down below. So you line it up, slide it into place, and then tighten down the yoke. And usually that's via that hand screw there. After you've gotten that on tightly, you crack the bottle. They fail to tell you that, but you open the bottle and then explain the procedure to the patient. Get out the device, attach the tubing. Okay, open the main valve here, I guess that's fine. And then select the appropriate leader flow. And after you've selected what you're going to take, prepare the device as necessary. In this case, it's a partial rebreather mask that she is inflating the reservoir bag on. And then place that device on the patient and snug it down. So pull the straps so that it's tight against their face, and then pinch the little clip on the nose to help it form to their face a little better, to improve the amount and quality of oxygen that they're getting. So in a concentrated form, oxygen is a medication, of course, and we're going to administer it according to indications and appropriate routes and forms. Things to keep in mind that all medications have potential side effects. Oxygen itself will not burn. Oxygen helps other things burn. So if we're talking about there's already flame, there's already fuel and oxygen, that makes for great fires. So the other thing about oxygen is oxygen sometimes is contraindicated at high levels for some patients, such as COPD patients. We'll talk more about that when we get to the respiratory section. It's not absolutely contraindicated. It's relative. It's something you just watch very closely. Oxygen is a vasoactive drug. It causes vasoconstriction, and it can decrease perfusion to ischemic tissues. That's why we don't bag people that are in cardiac arrest 100 times a minute, because it overflows them with oxygen and therefore causes their vessels to start to shrink up, including the vessels in their brain. Oxygen can be very drying to the mucous membranes, although in most cases in EMS, we're not with the patient long enough that we're going to have to worry about drying out their mucous membranes. Never withhold oxygen from a patient who needs it. So here are some indications: cardiac respiratory arrest, respiratory distress or failure, patients requiring assisted ventilation, inadequate respiration, which is basically inadequate tidal volume, respiratory rate outside the normal range, SATs below 95, altered mental status, difficulty in breathing, patients complaining of chest pain, other medical conditions that can cause hypoxia, such as seizure, stroke, overdose, toxic inhalation, wheezing, signs or symptoms of shock or internal bleed or severe external bleed, and then major or multi-trauma. Oxygen is supplied in a small portable tank. It's a pressurized oxygen, passes through the regulators, and the pressure adjusts it to 2000 psi. That flow meter then is connected to the regulator to allow for adjustment of the oxygen flow. So the flow meter reduces it, it regulates it, pulls it down so it's not so forceful, and then you change the flow that you want actually to come out of there. The cylinder, typically green or silver with a green band. Regulator only fits, oxygen regulator only fits oxygen bottles. Safety, again, pressurized gas, those bottles can be rockets. Be very careful with them. Secure them at all times. Petroleum products react badly with oxygen, so don't use any oil on or around oxygen equipment or grease. And it will, again, it enhances fire. So here we're using a non-rebreather mask. How does this work? The cutaway for the non-rebreather is oxygen flows through the tube, goes into the reservoir bag, and then there's a flap at the top of the reservoir bag that when you inhale, it pulls the ambient air, the side flaps, pulls them shut, and it pulls open the flap at the top of the reservoir bag. So the patient can then inhale the oxygen. When they exhale then it blows the flap at the top of the reservoir closed, and it opens the flaps on the side of the mask and allows it to be exhaled and removed. So delivery of a high flow oxygen in the reservoir bag, the flaps, so on and so forth, like I just mentioned. So talking about oxygen delivery devices, talks about nasal cannula, simple mask, venturi, partial rebreather, non-rebreather, and bag valve. Now, nasal cannula, generally 1 to 6, simple mask 6 to 10. We usually tell people non-rebreather 10 to 15. 15 is fine in my book, although in most cases you don't need 15. You should watch the patient deflate the bag. If the bag fully is deflating more than halfway, turn up your O2. So start them at 10 and then slowly increase it if need be. If the bag never even dimples, you're giving them way too much O2, you're just wasting it. It's just escaping into the atmosphere. So in most cases we use nasal cannula or a non-rebreather mask. All right, like I said, most times we will use nasal cannula or non-rebreather mask, of course bag valve mask. Some services still use some of the intermediate masks, such as a simple mask or a partial rebreather. I guess the way that most people really kind of look at it is you either need a little bit of supplemental oxygen or you need a lot. There's usually not much need for being in the middle there. That last column there that talks about oxygen concentration delivered, that is the FiO2, or the fraction of inspired oxygen. And with a nasal cannula, you can see you can give them 24 to 44% oxygen. With non-rebreather, you can be up to 95%. Bag valve mask, you can be 95+% as well. The simple mask is usually 35 to 60, and the partial rebreather 40 to 60. Partial rebreather and non-rebreather differ simply by the number of flaps they have. Non-rebreather has the flap at the top of the reservoir bag and on each side of the mask. If it does not have all three of those flaps, it is not really a non-rebreather. The venturi mask I'll bring your attention to, though, for a moment, is the venturi mask is used, and it's they actually have a combo. Well, there's a venturi mask on 412, and then they also have a venturi hooked up on the trach mask on 413. But a venturi mask allows you to precisely select the FiO2 you want to give. And if you look at the picture on 413, you can see, I guess, on 412 as well. There's a pink adapter on the one in 412. There's an orange adapter on the one in 413. By using those different adapters, they have different size vents that go with them, and that vent mixes X amount of oxygen with the room air. So you can usually select anywhere from about 24 up to about 60% oxygen by changing the little adapter that you put on there. So that's your venturi mask. COPD patients, that's probably the main category of patient you would use a venturi on. All right, so patients who have adequate ventilation but need high flow O2, non-rebreather is the mask of choice. Patients can struggle a little bit with this by having it over their mouth and nose if they feel a little claustrophobic. Nasal cannula, though, that is probably the more commonly used device for EMS delivery of oxygen. And it shows you basically how that works there. Notice that there's a little fin on the nasal cannula. I'll back up a picture here. You can kind of see the fin just right underneath the tubing there. Remember, that fin actually goes up against the lip. It doesn't point away or point out. It points up against it rests on the lip to direct the oxygen into the nose. So the oxygen goes up through their nose, mixes with whatever else they're getting from the room air, and that's what when they end up getting that 24 to 44%. The video on the nasal cannula. Remember, it's two short little prongs. on a set of tubing there placed in the external nares, just barely into the nares. It's a low flow device. You can go above 6 liters, but it sounds like a jet plane getting ready to take off, and it will be very drying, and there's a lot of pressure coming out of there if you go much above it. Sometimes it's all you got. Sometimes you got to move the nasal cannula actually into their mouth because they won't let you put a mask on them. So not that it's not intended for the mouth, but occasionally we do, and we'll put it at 8, 10, 12 liters simply for the fact the patient refuses to do a non-rebreather. Example of the Venturi mask, like I talked about, you can see a little closer the pink valve, and it'll tell you right on the side of the valve, set it at 6 liters, 7 liters, 8 liters, what have you, and that will give you the percentage or the FiO2 that you were looking for. So it's a relatively low concentration mask. They work very well, they're just not very commonly used. Other devices you may run into: simple mask. This has no valves, it has no reservoirs. It's simply a mask that covers their face, delivers mid to low levels of O2. And the tracheostomy mask is a specialized mask for those people who have trachs. You can see that on page 413. And that tracheostomy mask then fits around the top of their trach and sits snugly on their neck. So you may or may not use a Venturi with that. And again, used only for those people who are breathing well on their own. All right, so then it runs us into the discussion on your case study again. And so I hope you've reviewed that. Chapter summary: without adequate airway ventilations or oxygenation, the body cannot perform normal cellular metabolism. Without adequate internal and external respiration, hypoxia quickly ensues. Ensure that the patient has an open, adequate airway. The ventilations are sufficient, and oxygenation is appropriate. Immediate problems with the airway and breathing need to be addressed in that primary assessment. We have a large number of maneuvers and adjuncts that we can use to enhance ventilation, oxygenation, and airway management. You can find correctable underlying causes may help you actually improve breathing rather quickly. And we'll talk more about some of those when we get to the airway or the respiratory chapters. And alert patients are able to protect their airway better than you can protect it with mechanical devices. So if they're alert, that's good. They're going to maintain their own. Ensure you're applying techniques to correctly minimize complications. And your goal of airway management, positive pressure ventilation, and oxygen is simply to prevent hypoxia.